Welcome to today's webinar, Healthy Aging in Adults with Down Syndrome. Thank you for joining us. My name is Laura Crone, and I am the Project Manager for Research and Education at the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois, which is a suburb of Chicago. We are a healthcare clinic for adolescents and adults with Down syndrome ages 12 and older. Since opening in 1992, our healthcare providers have seen over 6,000 patients with Down syndrome. In addition to providing patient care, we offer a variety of research and education opportunities, such as this webinar. We also have an online resource library that has over 500 articles, videos, visuals, and webinar recordings that is available free of charge. So we will be referring to that throughout the presentation. Before I introduce our presenters, I have a few reminders. This webinar is being recorded, and the link to the recording and the slides from the webinar will be emailed to attendees within 1 week. The presentation portion of this webinar was pre-recorded, but there will be a live Q&A at the end of the webinar. Please submit questions using the Q&A option in your Zoom toolbar. We will be using that rather than raising hands and unmuting. The presenters for today's webinar are Dr. Brian Chicoine and Dr. Hannah Graham. They are both physicians at the Adult Down Syndrome Center and on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. In the interest of time, I'm going to share their full bios in the chat so you can learn more about them there. Thank you again for being here, and we hope you enjoy the presentation.
Thank you very much, Laura, and we welcome everyone to our Adult Down Syndrome Center webinar on aging in adults with Down syndrome. A pleasure to be with you today, and we look forward to also a Q&A at the end. So what are we going to talk about today? We want to talk about similarities and differences in aging in adults with Down syndrome compared to adults without Down syndrome. We want to discuss some common conditions that are associated with aging in adults with Down syndrome, including or perhaps particularly Alzheimer's disease. And then we want to discuss some strategies for supporting adults with Down syndrome and promoting their own health as they get older. So as you're probably aware, people with Down syndrome are living longer and healthier than any other time in the past. Look from these studies here that the life expectancy of people with Down syndrome in 1907 was only about 9. And in 1984 was about 28, and now the most recent data has it to be around 60. Now this is for higher income nations and for the white population, but the numbers for other individuals in the United States are only mildly less, and the difference is decreasing over time. So the differences in life expectancy is more similar in the different races in the United States. So why this big change? So the big difference in the late 70s and early 80s was the ability and the availability to treat congenital heart disease in children with Down syndrome. So you're probably aware that about 50% or so of children with Down syndrome are born with some sort of heart defect. And prior to the late 70s, early 80s, the ability to surgically correct those was not available. And so, with that ability to treat that large population of individuals with heart defects and to significantly prolong their life, the overall life expectancy has increased dramatically. And so now again, it's really pretty much doubled since the life expectancy pretty much doubled since the early 1980s, which is a pretty dramatic change. We'll talk about Alzheimer's disease here in a second, and we know unfortunately that the life expectancy is beginning to plateau around 60, and the high rate of Alzheimer's disease in people with Down syndrome is probably a significant contributor to that, which we'll talk about in a little bit. In addition to people living longer, not surprisingly then, there are more adults with Down syndrome living now than ever before. And if you look at this is the people with Down syndrome in the United States, a study that again, was updated in about 2018, and it shows an estimated number of people with Down syndrome to be about 220,000 people in 2018, and about 120,000 of those being adults. So it's really interesting if you go back and look at the population of the United States as a whole, particularly adults in the United States as a whole. The adult population in the United States from 1950 to roughly 2020 roughly doubled. But adults with Down syndrome increased by sevenfold. So a very significant change in the number of adults, number of people with Down syndrome in general, but particularly the number of adults with Down syndrome living in the United States over time. So we're going to focus on aging. So now we have this large population of individuals with Down syndrome that are getting older, which a generation or two ago we did not have. And so what are some of the health issues we want to address in this population of aging adults? So first thing is we want to look at, there are some similarities with any people that as they get older, and that includes many people as we get older, we become a little more set in our ways. And that's certainly true for some people with Down syndrome. And just like anyone, as we get older, we do tend to slow down some. And that's certainly true for people with Down syndrome as well. And then as we get older, we often will have a different activity preference. And so again, the activities we enjoyed when we were 12 or 20 or 30 may not be the activities we enjoy when we're 50 and 60 and 70 or 80. And so again, and that's not unusual for people with Down syndrome either. So in the past, it was not uncommon to hear people refer to a person with Down syndrome as a kid, whether they were 6 or whether they were 56. And clearly, that's not only incorrect, but it also puts one into a mindset that this individual is no different when they were 6 as when they are 56. And we know that that's clearly not the change, or clearly not the case. So we know that people with Down syndrome change as they get older, just like the rest of us. And so again, that may be different interests, there may be different physical capabilities. And then certainly what we're going to talk about here is some of the health patterns that we see in some of our older folks with Down syndrome. There are some differences in aging. One is we do tend to see people with Down syndrome have an earlier aging. What they look like they have earlier aging than in other individuals. So as we look at our individual with Down syndrome, we've looked at them for many years. It really looks like, but oftentimes before age 35, many people with Down syndrome often will look younger than their chronological age. But as they get older, as they get out past their mid-30s, up into their 40s, oftentimes people with Down syndrome seem to be older than their chronological age. And that it seems to continue to increase as people get older and older. And that would certainly fit with some of the common health conditions that we see at an earlier age that we're going to talk about here in a second. And then living arrangements sometimes can be different. If people with Down syndrome are depending on their parents often for their care, as their parents age, and then perhaps the home situation will change or the needs of the family will change. And so the living arrangements sometimes are not the same as they would be for someone without Down syndrome. And then again, as I mentioned, the health conditions, there are patterns, and some of these conditions do occur earlier in people with Down syndrome than they do in others. So what are some of those common conditions? So let's start at the top. We'll start with cataracts. So cataracts are more common in people with Down syndrome. And we do see children or infants born with cataracts. But I'm talking about the cataracts that tend to occur with age. And we do tend to see, they do seem to occur at a younger age in people with Down syndrome, probably also more common. They seem to be more common as well. And so oftentimes, we will see someone who has a change in behavior or a change in skills, and there's a concern perhaps they're getting Alzheimer's disease, when in fact, they're not seeing well because they've developed cataracts. And so that's something we want to make sure we're monitoring. And particularly when it begins to affect the person's vision, we do definitely want to make sure that they're being evaluated to consider treatment. And again, different perhaps in the rest of the population, the surgery may require general anesthesia for some or many individuals with Down syndrome. They're not able to sit still for the procedure like someone else might be able to without general anesthesia. And sometimes the eye drops that are required post-surgery can be challenging as well. So there are some things that sometimes can be a little more challenging with addressing cataracts in people with Down syndrome. Hearing loss also does seem to occur at a younger age, to the best of our ability, the best of our understanding. And then, like many of us, people with Down syndrome may not be able to explain their hearing difficulties, and that probably is even more true for people with Down syndrome than others. And so we do see that sometimes a hearing loss will present with a behavior change or a loss of skills, or an apparent loss of skills. So the individual, may be asked to do something and they're not hearing it correctly, and so they do something different. They think they do what they thought they heard, and so now they're labeled, excuse me, now they're labeled as having a behavioral problem or a behavioral change, when in fact they're just not hearing what's being asked. Similarly, someone is thought to no longer be able to follow directions because they're developing dementia, when in fact they may actually have hearing impairment and just not hearing the direction. So hearing loss is a common thing and can be subtle, and something we really need to be thinking of when any of these occurrences, the behavior change or loss of skills are occurring, particularly as folks get older, out in their 30s and 40s and beyond. I just want to add that we have had very good success with many people with Down syndrome using hearing aids appropriately and with benefit. And so certainly there are some that find them difficult, but many people will use hearing aids successfully, and we just don't want to assume that they cannot until we give that a try, if that's appropriate for them to have a hearing aid or hearing aids. Another condition that many of us face as we get older is osteoarthritis, arthritis of the joints, particularly sort of the wear and tear arthritis we think about as we get older. And there's a question that it does seem to, again, be more common in people with Down syndrome, and that may be related to the laxity of the joints. So many people with Down syndrome tend to have joints that are less stable or more lax, and that can cause recurrent chronic injuries, if you will, and that can lead to osteoarthritis. Also does probably seem to occur at a younger age. Probably it's underreported. We often find that people with Down syndrome have difficulty reporting that difficulty that they're experiencing, or having a difficult time appreciating their discomfort. And so oftentimes we'll see that the person presents with dysfunction of the joint. So the arthritis has progressed quite far before there really was a complaint. And so we really find that it ends up being something sometimes that will actually diagnose more from a functional standpoint rather than a pain standpoint that might be more evident in somebody else. So I'm going to turn the next two slides over to Dr. Graham, and I'll see you back in a minute.
Thanks, Dr. Chicoine. Hello, everyone. So I'm going to talk about osteoporosis. Now, osteoporosis is the thinning of the bones. And the reason that, of course, is a problem is that when we have thinner bones, we are more likely to fracture those bones and to have a break. Now, when we look at osteoporosis, for a long time, it has been reported to be more common in people with Down syndrome. The way we make the diagnosis of osteoporosis is with something called a DEXA scan. This is a scan that looks at the density of the bones. We make the diagnosis of osteoporosis in people with and without Down syndrome with a DEXA scan. It's kind of interesting, though, because there's a growing body of evidence that DEXA scans may not be as accurate as we thought they were when looking at the bone density of people who are of shorter stature, which would be most people with Down syndrome. This growing body of evidence suggests that DEXA scans may inaccurately underreport the bone density in people with shorter stature, which might mean that the DEXA scan is reading thinner bones than really exist for people with Down syndrome. There are theoretical bone scans that might be more accurate than a DEXA scan for looking at the bone density in people with Down syndrome, but those are really only available in research settings and not something that a doctor can order to have done for their patients yet. When we think about bone density and osteoporosis, what we're really trying to get to, though, is the idea of preventing fractures. We don't want people to be breaking bones as their bones get thinner. It's also interesting that while osteoporosis is reported to be more common in people with Down syndrome, there are actually very few studies and very little information about the rate of fractures in people with Down syndrome as they are aging. So this is kind of interesting, and it means that we probably have a lot we still need to learn about the bones as people with Down syndrome are getting older. In the JAMA article looking at the care of adults with Down syndrome, they actually reported that there is insufficient evidence for screening for osteoporosis in people with Down syndrome. That really means that it often comes down to a shared decision-making discussion between a patient and their caregivers and their provider about whether or not osteoporosis screening makes sense for each individual patient with Down syndrome. Now, when we think about osteoporosis, if we make that diagnosis of osteoporosis, we need to think about the treatments. There have been no studies evaluating the medications that we use to treat osteoporosis in people with Down syndrome. So we just don't know how they work in people with Down syndrome. We don't know if they are effective or if they have any differences in their side effect profile. There is also some interesting evidence, growing evidence, that people with Down syndrome might have differences in their bone formation pathways. The ways that their bodies build and break down bone might just be a little bit different in people with Down syndrome. If that's the case, some of the medications that we use to target those bone formation pathways might work differently in people with Down syndrome. We can't know until we have a chance to study it. So overall, with osteoporosis, people with Down syndrome, as they're aging, may face this diagnosis and should, of course, be concerned with bone health. But actually, we still have a lot to learn about osteoporosis in people with Down syndrome. All right, let's go to the next slide. Next up is menopause. So fun. When we think about menopause, of course, is when a woman stops having her menstrual cycles. It is defined as when a woman has gone a full year without a menstrual cycle. The average age for menopause in women in North America is around age 51. In women with Down syndrome, that average age of menopause is reported to be a little bit younger, often quoted around age 46. So that's about 5 years younger than women without Down syndrome. I like to talk about perimenopause a little bit too. Perimenopause can be the years leading up to menopause when a woman's menstrual cycles might become more irregular and just different. In women without Down syndrome, we know that this can last for many years, actually. It has never been studied in women with Down syndrome, as far as I can find, but it makes sense to understand that perimenopause is probably also happening in women with Down syndrome. So a woman might be experiencing irregular periods for months or years leading up to the cessation of her periods with menopause. The symptoms of menopause in women with Down syndrome are typically the same. Women can experience hot flashes, changes in weight, changes in mood. Hot flashes can be very difficult for some women with Down syndrome to describe, and oftentimes it's caregivers who might report to us some of these symptoms of menopause. When we think about the treatments for menopausal symptoms in women with Down syndrome, they are the same as in women without Down syndrome. However, they also have not necessarily been studied in women with Down syndrome. There are some interesting questions about hormone replacement therapy, well, in women without Down syndrome and in women with Down syndrome. I think one of the things that might be important to keep in mind is some of the side effects associated with hormone replacement therapy. They can be associated with the risk for blood clots. The risk for blood clots has not been evaluated in adults with Down syndrome, but we know that adults with Down syndrome do seem to have other risk factors, like autoimmune diseases, that might increase the risk for blood clots. Therefore, we might need to think about that possible increased risk of blood clot when evaluating whether or not hormone replacement therapy is a good option for women with Down syndrome. It might come down to a risk and benefit discussion where we talk about the risks of the medicine, but also the benefits, because sometimes those benefits are worth more than the risk. We just have to have a conversation with the care team for each woman. Besides hormone replacement therapy, there are also medications that can help with some of the vasomotor, hot flash symptoms of menopause. These have also not been studied in women with Down syndrome. But again, the treatments are the same for women with and without Down syndrome. Sometimes when we talk about menopause, you hear about an interesting connection with memory. This is because there have been some studies that showed that women who experienced menopause at an earlier age it was also associated with an earlier age of the diagnosis of dementia or Alzheimer's. There's this idea that there's some sort of link between that earlier age of onset of menopause and that earlier age of onset of Alzheimer's disease. This hasn't been studied enough, and we don't know enough to make any treatment recommendations based off this information. But I do like to share it because I think that it's a field that people are continuing to study, and we might hear more about it in the years ahead. Dr. Chicoine, back to you.
Thank you, Dr. Graham. All right. So as Dr. Graham mentioned, the article in the Journal of American Medical Association describes the healthcare guidelines, and then there's a version, written more for the general population, for families and other individuals, not healthcare professionals, who and the global medical care guidelines for adults. And so those are available, and they do address the issue of osteoporosis, for example, that Dr. Graham was talking about. And there's a number of other topics that are addressed in those guidelines. And then there's actually we're working on round 2 of those guidelines, but which will address some additional topics in the coming year or two. So let's jump over to Alzheimer's disease, which many of us think of with aging, in people with Down syndrome particularly. So what is Alzheimer's disease? So it's a progressive neurological condition. It's a neurodegenerative condition where the brain and the nervous system degenerates. It certainly affects the brain, but it also affects other parts of the nervous system as well. And it's a type of dementia. So dementia is sort of an overriding term, and there are many types of dementia. There's dementia related to vitamin B12 deficiency, and there's dementia related to untreated underactive thyroid and other causes of dementia. But one of the types of dementia is Alzheimer's disease, and that does seem to be the one that is most common in people with Down syndrome. And when you look at under the microscope of the brain of an individual with Alzheimer's disease, you see what are called plaques and tangles, and those are changes in the cells and the tissue in the brain. And these microscopic changes are consistent with what we know as Alzheimer's disease. And we know, unfortunately, that by age 40, nearly all people with Down syndrome have the brain pathology, have these plaques and tangles by the age of 40 in their brain. So, and then you can see that in the diagrams there that as the more and more of the brain tissue becomes affected by these changes. So why is this more common in people with Down syndrome? Well, we know on the 21st chromosome, the gene for amyloid precursor protein is present. And we do know that people with Down syndrome have an extra 21st chromosome. And this extra APP gene, so now there's 3 of these genes instead of 2, because they have this extra gene, there's some good evidence to indicate that this is a very significant contributor to this increased Alzheimer's disease in people with Down syndrome. So in a sense, it's almost like they have more effect of that gene because of having the extra chromosome. And so, but there may be more to, there seems probably more to this than just the APP, although that seems to be a very important factor. There's concern about chronic inflammation that may be going on in people with Down. There's thought to be going on in people with Down syndrome in throughout their body, but particularly in their brain. And what is the impact of that on development of Alzheimer's disease? Certainly more to come on that, where people are still learning. And then what about metabolic abnormalities? We know certainly from the non-Down syndrome population that there does seem to be a relation to for example, to blood sugar and some are even calling Alzheimer's disease type 3 diabetes. And so really, how does that impact? A lot to know, a lot to learn on that in the people without Down syndrome. But what is the impact of that on people with Down syndrome? Certainly, a lot more needs to be learned, and particularly when it comes to how might we make a difference in that, or how might we prevent then Alzheimer's disease from occurring because of how addressing these issues. So certainly, a lot of work being done right now, and more information to come. But the interesting thing is that despite age 40, nearly all people with Down syndrome have brain pathology of Alzheimer's disease. The symptoms of Alzheimer's disease are uncommon before age 40. So these changes in the brain have been going on for a number of years, or being developed over the number of years. But really by before age 40, it's pretty uncommon to have a symptom of Alzheimer's disease. So again, despite these changes being in the brain, symptoms don't actually become occasionally, but typically are not present before age 40. However, it is quite common. Estimates vary, but about 55% in those, actually that's a typo there, it should be 55% of those ages 50 to 59. So it's certainly a significant numbers. And in those age 60 and over, greater than 75%. So again, very significant, very common problems, unfortunately. And the average age of diagnosis is in the mid 50s, and the average age of death, again, so the course of the disease, 4 to 5 years is on average. Certainly, people can have Alzheimer's disease, symptomatic Alzheimer's disease, for many more years than that, and some unfortunately even much shorter. So again, those are averages, but just things to consider as when looking at the population as a whole. And then, what are the symptoms? So again, it's often stated, although I don't think it's 100%, but it's often stated that all people with Down syndrome will present with psychological changes first. I think those are common, but I don't think they're universal. But that may be subtle things like a change in personality, or we know that a lot of people with Down syndrome use self-talk as they go through the course of their day, and so we may see that sometimes people their self-talk becomes more animated, sometimes more agitated. Sometimes where they knew before that it was probably okay to self-talk in your room, but maybe not, in the middle of a grocery store or something, where they begin to lose that discrimination of where and when they, self-talk would, most serve them the best. And so again, they may lose that ability to judge that. And then the other thing is, we know a lot of people with Down syndrome like to adhere to routines. And so as we see some people develop Alzheimer's disease, they actually become very, very rigid and so stuck to their routines that they have no flexibility. And then on the other hand, some people lose their routines. And so they, the nice routines they had that really served them very well, now become dysfunctional, and they're no longer able to really use those routines to benefit getting through their day. And again, other psychological changes may be common, and it may be anxiety or depression. Memory impairment, just like in anyone else, is a common symptom. And then loss of previously mastered skills. It's very important to consider it's not whether someone has the skill or not, it's whether they had it and they're losing it. And that's really important. So if someone never had a skill, the fact that they don't have it now does not mean they have Alzheimer's disease. It's a skill that they had that now they no longer have. They've lost that skill. And as the disease progresses, we'll see incontinence, urine and stool very commonly. Weight loss is an interesting one. It's been known for years that in the non-Down syndrome population of people that develop Alzheimer's disease, weight loss can be an early symptom, can be a later symptom as well, but can be an early symptom. And there was a study done in the last several years looking at people with Down syndrome as they got on in their mid-30s, and they did notice that some folks began to lose small amounts of weight as early as their mid-30s, which does, they did think seemed to be associated with ultimately developing Alzheimer's disease. And so again, that may be an early sign of Alzheimer's disease in people with Down syndrome as well. Seizures are part of Alzheimer's disease in anybody, but they seem to occur much more frequently in people with Down syndrome. perhaps even up as high as 85% of people with Down syndrome who develop Alzheimer's disease, versus maybe up to 25% of people without Down syndrome who develop Alzheimer's disease. And also, in our experience, they tend to be, not always, but can be earlier in the process. And so it's often a late finding in people without Down syndrome who have developed Alzheimer's disease, but in people with Down syndrome, it may be an early finding. In fact, we have seen some individuals that had none of these other symptoms who had a seizure in their 40s, and then within a year or two started to develop these other symptoms. So, and at least in our experience, on occasion, it was the very first symptom that people experienced. And then as the disease progresses, an unsteady gait may occur. Unsteady gait may occur, and people begin to lean even when they're walking or even when they're sitting. And then ultimately, it can make falling become a problem, and again, even make walking at all a challenge. And again, this is not unique to people with Down syndrome. I just read an article a couple of weeks ago on again, not in people with Down syndrome, but in anybody with Alzheimer's disease. Falling can be a symptom of developing Alzheimer's disease, or a finding of progression of the Alzheimer's disease. And then swallowing difficulties, also called dysphagia, seems to be a very common symptom in people with Down syndrome who develop Alzheimer's disease. And in our experience, this is often a later finding, but also a very challenging finding and a very disabling finding, and that people will start to develop recurrent aspiration pneumonias, where they actually aspirate food or liquid or even their own saliva and develop pneumonia, and that can unfortunately often contributes ultimately to the person's passing, to their death, because they get these recurrent pneumonias that can be so very threatening, life-threatening for the individual. So how do we think about screening for these individuals where you got all these symptoms? What's a way to kind of begin to think about screening for that, and looking to see, are there any symptoms that are beginning to occur? So the National Task Group on Intellectual Disabilities and Dementia Practices developed a screen called the NTG-EDSD. You can see it there, and the link there, when you get the slides, the link there can take you to that. It's about a 6 or 7 page document, and it really is intended to do at home. It's not a diagnostic tool; it's a screening tool, and so you can look at that with your family member and see if there's any changes, and then particularly doing it over time and watching for changes over time can be very, very helpful. A one-time assessment may not give you the information you're looking for, but to watch for a change over time, probably think about every year, but every 6 to 12 months to consider a screening. And in the healthcare guidelines, the global healthcare guidelines I mentioned a moment ago, in that the recommendation was to consider screening around age 40, and to start to begin to look for some of these symptoms. And so when we are looking, then ultimately we're looking for a pattern of decline that I talked about, the symptoms, and this screening tool can help you look for that pattern of decline. So how do we make the diagnosis? First thing I would mention is a term called overshadowing. Overshadowing means that we tend to focus on one thing and not look at other possibilities. And so in Down syndrome, overshadowing often refers to, someone that has a symptom that may be a symptom of underlying health condition, and the physician or the provider only looks at the fact that they have Down syndrome and they ignore the other possibilities. Well, and we also see this in Alzheimer's disease, because we know that it's so common in people with Down syndrome. Oftentimes, a person with Down syndrome will be assumed to have Alzheimer's disease, no matter what the decline and no matter when in life that this decline occurs, this loss of skills occurs. So I've gotten many, many phone calls over the years, similar to my 19-year-old son has been diagnosed with Alzheimer's disease. And so again, it really did seem like just because the person has Down syndrome and because they had a decline in skills, that someone just went ahead and assumed that they had Alzheimer's disease. And that's really not it's not medically correct, and it's not really fair to the individual either, because we really want to look and see, are there other causes that we can address. So how do we do that? Well, certainly, if there's a screening tool or there's some concerns that are a screening tool that's abnormal, and there's some concerns, we want to start with a good history and physical exam, like in all things in medicine. You want to start with a good history and physical exam, and particularly want to be looking for symptoms or signs of other causes. Is there something else going on there that we might be able to treat? Thyroid, for example, or B12, like I mentioned before. So some of these things that other causes that can contribute to someone having a decline in skills or further cognitive impairment. We want to potentially look at neuropsych testing. Neuropsych testing is typically done by a psychologist, and that psychologist will do a battery of tests. The battery of tests done in the non-Down syndrome population, for the most part, have some real significant limitations in people with Down syndrome or other intellectual disabilities. They're really not designed for those individuals. And so if these are going to be done, you really want to look at tests that are more specifically designed for people with intellectual disabilities and or Down syndrome. And sometimes it can be hard or difficult to find a psychologist who is versed in these tests for people with Down syndrome. And so sometimes these tests can be challenging to contribute to the overall diagnosis, because it's hard to find someone to do them. And then the other consideration, we certainly want to look at blood testing and brain imaging. Blood testing, again, just the examples I've used a couple times, make sure we're checking their thyroid, make sure we're checking their B12, check their kidney function, check their blood count, check for a variety of things that we know can cause a person to decline in skills if they're abnormal. And the other consideration then is, should we be doing some sort of brain imaging, an MRI or a CT of the brain? MRI typically is going to give you more information, but none of this imaging will give you specific information to diagnose dementia. Alzheimer's. You're really looking more to rule out other things, or perhaps looking for atrophy or shrinkage of the brain, which supports the diagnosis but doesn't make the diagnosis. So sometimes getting these testing, particularly an MRI, can be very challenging for an individual. And so some individuals were looking at potentially doing a general anesthesia in order to get it done. And we do know that sometimes general anesthesia can make people more forgetful and cause more brain dysfunction. So really have to kind of weigh that, the pluses and minuses to getting those scans to aid in the diagnosis. So what about treatment? So I'm going to start with the boxes, the lighter blue boxes on the left, and then we'll come to the gray ones here in a second. So we talked about there's a lot of symptoms that can be significant in people with Alzheimer's disease, with or without Down syndrome. And again, so there may be depression, there may be a change in behavior, or a sense that they're upset or agitated, seizures, anxiety, sleep challenges, and even pain. Pain not being associated with Alzheimer's disease as much as having underlying pain that they're not able to report. And in some people with Alzheimer's, they seem to be more aware of their pain, and so that may become a problem as well. So a number of these are just a partial list of the symptoms, and so each of those has a potential treatment aside from Alzheimer's disease. We can treat sleep, we can treat anxiety, we can treat pain, etc. Certainly seizures. And so certainly want to look at all those things and make sure we're assessing for those and addressing those. So even if a person does have Alzheimer's disease, treating their depression or treating their seizures is still going to give them benefit. And so we want to make sure we're treating those. And then again, there are certain medications that can be more helpful in a person with Down syndrome and Alzheimer's disease for any of these conditions. And so to limit the negative effects on the brain of the medication and to optimize the benefits. And so I won't go into all the details of that, but there are differences, different medications you can use that are beneficial. And then what about treatment for Alzheimer's disease itself? And so for a number of years, there's been two groups of medications, one called the cholinesterase inhibitors and one the NMDA receptor antagonists. And the NMDA receptor antagonist, there's only one in that category, memantine or Namenda. And then there's a number of these cholinesterase inhibitors. Unfortunately, the studies done on people with Down syndrome really have not concluded that they were beneficial. In a lot of ways, there's just not enough data, but in general, not data that clearly shows benefit. And clinically, we would say find that that's similar, that we have not seen a much of a benefit from treating with these. There are newer medications, the amyloid beta therapies, which you may have heard about in the last few years. They do seem to have much more optimistic that they're going to have benefit in the studies so far in people without Down syndrome who developed Alzheimer's. There does seem to be more benefit. But the challenge is, as Hampus Hillerstrom from Lumine IDSC said a couple of times that I was at a conference he was speaking at this summer, he said, of the 13,000 people with 13,000 people that were tested with these medications, none of them had Down syndrome. And so it's a very unfortunate situation where the population that has more Alzheimer's really has not been included in these studies, unfortunately. And there are some potential side effects, including what are called microhemorrhages, bleeding in the brain, that may actually end up being more common in people with Down syndrome. And so we really need to get these safety studies, and there is now a commitment that at least one pharmaceutical company is looking to start a study, and at least as of a couple of weeks ago, it had not started yet when I last looked it up. That's very encouraging that we're now moving forward with making sure these are tested in people with Down syndrome. So hopefully we'll see some real important discoveries in the next few years. One other thing I'm just going to touch base on is with regards to Alzheimer's disease, as unfortunately we don't have these good treatments yet to reverse or to stop the disease, and so we do at times have to just we talk about advanced directives, meaning as the disease is progressing and we know that end of life is coming, what are some of the guidance that the individual and or their family would like us to include in their care. So there's a real nice, I won't go into great detail here, but there's a nice booklet put out by NDSS along with NTG and the Alzheimer's Association, that the link is there. And then also Dr. Mary Stevens and I gave a presentation for the Down syndrome in New South Wales in August. That recording has not been posted yet, but hopefully will be soon. And so that's an entire presentation on this topic. And so I certainly can't do justice to it in a couple of minutes. But if you'd like to learn more information, feel free to take a look at either one of those. And then the other topic I think doesn't get a lot of discussion is how other people with Down syndrome are affected by a person with Down syndrome developing Alzheimer's disease. And so certainly in individuals that live in group settings where there are other individuals with Down syndrome that they live with that are developing a dementia or Alzheimer's disease, it's clear that something is not right or something's different. And certainly even certainly a lot of people with Down syndrome know a lot of other people with Down syndrome, and they see friends or family or coworkers or whoever develop Alzheimer's disease symptoms and wonder what's going on, and certainly hear that it is more common in people with Down syndrome, and then wonder what about me? How's this going to affect me? So I think the first thing to consider is that in our experience, it does impact some individuals with Down syndrome. They see what's going on around them, and they have a concern, and it can cause fear and anxiety, and it can cause resentment. We've had individuals again living in residential facility, group facilities, where because someone has developed Alzheimer's disease, they no longer have to do chores, for example. They're no longer capable of doing the chores, and so they no longer have to do chores. And the individual without Alzheimer's disease gets upset. How come he doesn't have to do them, but I do, for example? And so that can be an issue. On the other hand, sometimes we've seen individuals with Down syndrome really that having a friend or someone they live with developing Alzheimer's disease, it really sometimes brings out the best caregiver in these individuals. And we've seen some folks really rise to the occasion and really become very helpful to their friend who is developing Alzheimer's disease. So I can't do justice to this in just a couple of minutes, but I think that these are just some things to consider as if and when you get into this kind of situation. So Dr. Chicoine, you've talked about some challenging things so far. let's talk about how we might have a healthier aging as we go forward. And so let's address that. So certainly promoting healthy aging, and just like anything we address, we really want to look at mental health, physical health, and social health. And these are clearly intertwined, and these are all related to each other. And so we really want to try to promote all three, and promoting one oftentimes has a positive impact on the other two. And that's with regards to health promotion, but as well as medical care as well. These really are very intertwined. And they're probably even more intertwined in people with Down syndrome because of the communication issues. And some people with Down syndrome communicate very well. Others have a challenge, communicating their discomfort, whether it be physical or mental health or social health. So it may come out more evidently in one of the other areas. So someone is having discomfort and they're not able to tell us, having a physical pain and they're not able to tell us. And so it presents as a behavioral change, more of a mental health challenge. And so missing that there's a physical health component not only is likely to, lead to less accurate diagnosis, also likely to lead to less successful treatment. So you really want to look at all three of those together. So lots of things can promote, health as we age. Healthy eating, we certainly want to encourage physical activity, recreation activities, sleep, stress management, relationships, employment and vocational opportunities, and good hydration. And we're going to address each of those in a little more depth here. So certainly we want to maintain a healthy diet and weight if at all possible. No one diet seems to be best as far as preventing Alzheimer's disease, for example. But there are diets called the DASH diet or the Mediterranean diet or the MIND diet, which seems to combine Mediterranean and DASH diets. And those do seem to have some data behind them in people without Down syndrome as far as potentially preventing or delaying Alzheimer's disease. So certainly looking at those for more information if you're interested. Again, they can give you more details on the information. The other question is intermittent fasting, and again, really, there's just not enough information at this point to tell us with regards to preventing Alzheimer's disease and the overall impact on healthy aging. But a lot of people are really looking at that as time goes on here. So, what are just some general tips for healthy eating? Before you go and take a look at more information, but I think certainly reducing processed foods in the diet is a good general consideration. Making sure we're getting enough green leafy vegetables, and you can add them to meals if the individual is resistant to eating them. You can add them to pasta or soup or sauces or eggs. Make food swaps. Use grilled food instead of fried. For pizza, which seems to be very popular in our practice, use a cauliflower pizza crust instead of a regular pizza crust. And for noodles, use zucchini noodles instead of wheat or processed food noodles. And so again, just some little things you can do again to just try to make some of these changes. The other thing we really encourage involving the person in planning meals and shopping. So include the person with Down syndrome in these, and really not only very capable of doing it in many cases, but also we find that it really does help people to follow the healthy eating guidelines better. Look at food labels and use apps and visuals. We included some of the visuals there, but again, things that people can follow. For example, the green, yellow, red there. Foods that sort of eat without feeling restricted, and then yellow being a little more cautious, and red being not never but infrequent. And then the other thing which is helpful is discuss which parts of the meal to have second. So more fruits and vegetables rather than more of the meats or the starches. And then hydration, and this I just cannot emphasize enough. We over the many years looking at people with Down syndrome and listening to their stories and looking at their labs, I'm convinced so many people with Down syndrome just do not drink enough fluids, and that's unfortunately not unique to people with Down syndrome. Many of us could say the same thing about ourselves. But again, particularly as we get older and perhaps our thirst mechanism is less well in tuned, and we maybe don't feel as thirsty, and so we don't make our, don't naturally feel compelled to drink. We really kind of have to kind of encourage ourselves and maybe have others encourage us as well. And again, being dehydrated, fatigue and dizziness and confusion, all symptoms that you can see in people with Alzheimer's disease. But when they're caused by dehydration, they can be more reversible, at least in some situations, or and at least temporarily. So again, hydration is so important. And the picture there is we have a video on where Julia demonstrates the healthy drinking and gives you some other tips on making sure you're well hydrated. And she has Down syndrome, and so that's a good tool to use with other people with Down syndrome to watch that video and encourage them to drink enough fluids. So we want to really look at limiting pop or soda. We have a lot of folks that don't like water, and so just trying seltzer or sparkling water, maybe a little flavored water with fruit. And again, sometimes it's just as the visual there. Sometimes it's helpful just to have a visual where you check off or you circle or whatever that you've drunk, that you've consumed X number of bottles of water or X number of cups of water, and just to kind of serve as a reminder to make sure we're getting enough fluids as we go through the day. The other thing, which again has not been, none of these really have been shown to prevent or delay Alzheimer's disease in people with Down syndrome. But we know they're just good for general healthy aging. But there are some data in people without Down syndrome that these may actually delay or prevent Alzheimer's disease as well. So we certainly we don't know that they work for people with Down syndrome, but we do know that there's so many other good reasons to do them that if ultimately it turns out that they also help delay or prevent Alzheimer's disease, that'll be just one more bonus. And physical activity is one of those things. Recommend at least 30 minutes at least 5 or more days a week. There are so many benefits, and we really encourage incorporating a variety of types of physical activity. So oftentimes we think of aerobic activities as exercise, but we really want to look at strength or resistance training and stretching. The other thing is I didn't put it on there, but balance is so important. We know that as we get older, with or without Down syndrome, that balance becomes more impaired or less functional, and so. Again, if we can prevent falls and by improving our balance, that has many excellent health benefits. And again, as I mentioned before, preferences may change with age. And so, I've heard many times, my son no longer, likes to play baseball. And I think, well, he's 45 years old. I'm not playing baseball at 45 either. And so, find something else that, the person enjoys, but, pick something that they enjoy and they're going to, go with. Important to think about for many people. You really want to make it fun. That's one of the key to exercises. What exercise to do. In some ways, it's the one you'll do and the one you enjoy. It may be that you listen to music or watch TV while exercising. It may be that you're active with others. You might turn it into a game of some kind. So really looking at how you can be active throughout the day and how the person with Down syndrome. And there are lots of resources on our webpage that we'll show you in a second here. Lots of resources on the webpage, all sorts of different organizations, National Down Syndrome Society, Gigi's, Special Olympics have lots of good recommendations on exercise. Breaking it into shorter periods throughout the day. Some people with Down syndrome, possibly because of some blood flow issues in the legs, may find longer stretches of exercise more challenging, and so breaking it into multiple shorter periods may actually be a more functional way of doing things than trying to do one long 30-minute or even longer stretch. And then build it into the calendar or schedule. Really make it like an appointment. I'm gonna exercise at 9 o'clock or 10 o'clock or whatever the case may be, and really build it into the calendar and the schedule to really make sure that we're doing it on a daily, at least 5 times a week basis. The other thing that's so important with regards to health, aging, and health in general is good sleep. And we know that unfortunately people with Down syndrome have a higher rate of sleep apnea, which is where there's pauses in the breathing while the person is sleeping. Typically, in people with Down syndrome, it's obstructive, meaning The brain is telling the body to breathe, but the airway gets closed off as they're breathing in, and so they're not exchanging the gases in the normal fashion. And unfortunately, we know that sleep apnea is more common in people with Down syndrome. And it's also been shown that people with intellectual disabilities in general, including people with Down syndrome, tend to have some irregular sleep patterns compared to the rest of the population. And again, probably not terribly surprising that in that the sleep centers are in our brain. The the centers of the brain, the centers that drive our sleep are in the brain. And we know that because of having Down syndrome, the brains of those individuals with Down syndrome are not the same as others. And so it's not surprising that sleep is a problem. So really working on, what can we do? We want to work on a sleep hygiene. And we'll talk about a little bit more about that in just a second. And that's really a routine before bed, not looking at like iPads and other screens just before bed, having a routine before bed to kind of settle us down and to go to bed in a more routine fashion. And then certainly in people with Down syndrome, so important to treat sleep apnea, which is more common. There was a study done several years ago that showed untreated sleep apnea in people with Down syndrome was associated with Alzheimer's disease, associated with increased changes in the brain, the plaques and tangles that I talked about before. So again, really trying to diagnose and assess and treat sleep apnea in people with Down syndrome is important for so many reasons, including the possibility that it can delay or prevent Alzheimer's. So again, aside from sleep apnea, we do want to make sure we're creating a bedtime routine. Look at the current medications, other medications that might be disrupting sleep. Is there a natural product that might help this sleep? Melatonin. Some people will use valerian root, things that might help the individual sleep. Magnesium helps some people sleep, magnesium supplement. And then if you're doing all those things and sleep is still a problem, prescription medication may be indicated, and that can be discussed with your provider. Another thing we know from the non-Down syndrome population is the importance of mental stimulation, paid or volunteer work, games, puzzles, activities, all these things that stimulate our brain and keep us help with healthier aging. And so we know that, again, in the non-Down syndrome population, there may even possibly be a benefit in delaying or even preventing Alzheimer's disease. So really trying to look at these things. I love the term that when we retire, we should retire to something rather than from something, meaning we really want to make sure that there's new things that we're going to have in our lives that stimulate our brain and keep us physically and mentally active. And again, it's going to sound a little repetitive, but again, the activities as well as the exercise may change as an individual ages. And so things the individual enjoyed in the past, may they not enjoy now, and vice versa. So really looking at, what is the person enjoys. I don't know that maybe it's just our practice, but I can say I have seen so many word searches over the course of years with people coming in with Down syndrome. So many of our patients love word searches, and that's a good brain stimulating activity. And then we certainly know from the non-Down syndrome population the importance of social engagement with healthy aging, particularly with healthy brain aging. So family, friends, housemates, recreational activities. There are data in the non-Down syndrome population that show that hearing impairment may actually contribute to the onset of Alzheimer's disease. And the link to that, the sense of that is that might actually, the real key to that may be that it reduces social engagement when you have hearing impairment, when you develop hearing impairment. So again, really looking at that and want to make sure that we include social engagement and also addressing the issues of hearing to make sure that people are able to stay actively involved with friends and family. And again, here we go again, change the frequency and or length as an individual ages. So people may have different things they're interested in. Perhaps they're no longer, want to have an employment, but are there volunteer activities? Is there a park district program? Or are there events at the library that they can participate in? Best buddies, other things that people might get involved in to keep them socially engaged and mentally stimulated. And then the other correlate to that is really looking at what about mental well-being? We know that stress can be a significant problem for a healthy aging. And again, there are some, as we age and we develop some other health issues and changes in our families and the death of parents or siblings or spouses, life stressors can be associated with aging. And we know that people with Down syndrome experience stress. Some that don't have an appreciation for people with Down syndrome. Well, they don't have stress in their life, and that's really not true. And so we really want to take a look at what is the person sharing with us? How are they expressing the stress? What can we do to help them? And really, one of my all-time favorite videos that we have on our webpage is this tips for dealing with the stress video. I really encourage you to take a look at it. It's a 4 or 5 minutes, and Cindy, the woman on the right, has some wonderful descriptions for stress and the way that, and then the two ladies there have talk about how they manage the stress. And we do know that people with Down syndrome, at least in our experience, in our sense, that people with Down syndrome have what we call empathy radar, where they can really sort of pick up on the feelings of others around them. So if there's a lot of stress going on around them in the family, for example, they may be feeling that as well and may not be able to express that. So really trying to help them address those concerns. And then as people age, they may slow down, and just like the rest of us. And so sometimes if we don't appreciate that the individual with Down syndrome is changing over time, the expectation may be that they still work as fast as they did before. They may attend activities that were the same as before that they're no longer really able to keep up with. So really trying to match the activities to where they are in life. And again, that's not unique to people with Down syndrome. That's true for all of us. It really does help them continue to be involved without being overly stressed by what they're involved in. So again, practice calming strategies. I talked to individuals with Down syndrome and their families that we want to practice these calming strategies before you need them. And so, so that when you do have a stressful situation, you're ready, you've practiced, you know what to do. Counting to 10, taking deep breaths, walking away, coloring. For years, it was, someone would say my son or daughter colors, and I've been told that that's age inappropriate. And I said, if they enjoy it and they find it relaxing, absolutely, that's fine with, I think that's fine. And then the rest of the world discovered that coloring is relaxing, and now many people are coloring, and so it's just the people with Down syndrome were just ahead of their time, and that that is an activity that can be very relaxing. Strategies, reframing thoughts, asking for help. You want to make sure people are asking for help, and use I statements. I have this challenge. And work with a mental health provider if needed, and consider therapies, whether it's talk therapy or music therapy, or art therapy. And we have a whole lot of resources on mental health and promoting mental health on our webpage. And when you get the slide, you can put that link there. So what are some of the key points from today? So the life expectancy of people with Down syndrome is about 60, and it has significantly increased over the last couple generations. There are similarities and differences in the aging process between adults with Down syndrome and adults without Down syndrome. Some health conditions are more common in adults with Down syndrome as they age. And there are many lifestyle choices that people with Down syndrome can make to be healthier and to be healthy as they age. So if you're looking for some additional resources, the Down syndrome Medical Interest Group is again, it's designed for health professionals. But you might find some of the information, non-professionals may find it helpful as well. And there is something called Project Echo, where if you live in an area where you don't have an expert per se in Down syndrome, your healthcare provider can present a case, de-identified, meaning they don't tell us who the individual is or give any identifying information about the individual. But they present this in a Zoom meeting to a panel of Down syndrome experts, and then we share information with that healthcare provider, and they can take that back to your home to share with you and in treating the individual with Down syndrome in your home or in your life. So that's a nice resource. On our Adult Down Syndrome Center resource page, we have lots of information. A resource library, an email list, Facebook page, Instagram, all things that are sharing information about the health of individuals with Down syndrome. So I encourage you to take a look at those. And then we have lots of articles on our webpage that you might find helpful with regards to aging in particular, but a wide variety of topics, as well as videos and visuals that can help individuals with Down syndrome to promote their own health and their own healthy aging. We have a series of webinars and podcasts of some that we have done and some others have done that you might find helpful. And then again, on our webpage, we have a resource list. And this, when you get the slides, you can just use these to go address a specific topic or look at a specific topic. And then we have a number of references. If you wanted to go into the medical literature, you can find, again, when you get the slides, you can take a look at those if you're interested. And again, this is the list of our resources. Please feel free to use those. And now we're going to stop and we're going to open it up for questions and answers.
Great. Thank you so much for that presentation. We are going to jump in to the Q&A now, and we will try to get to as many in the next 5 or 10 minutes. So the first one is, do you recommend vitamins for people with Down syndrome as they age?
Yeah, that's a good question. There is, we have a nice article on our online resource library that goes into much more detail about this. But first thing we really do recommend is really looking at the diet. And so if there's really a question whether the person's getting adequate vitamins in the diet, an evaluation by a dietitian or nutritionist would certainly be a good first step. But particularly things to consider, certainly where we live in the, further north in the hemisphere, a lot of people do not get great sun exposure throughout the year. So certainly the consideration of vitamin D supplement may be indicated. And then as we get older, sometimes we have develop vitamin B12 deficiency, and people with Down syndrome may be more at risk of that. So probably considering testing for that and then considering supplement would be a possibility. Zinc supplement may help reduce infections. There's very limited data, but some data that suggests that in people with Down syndrome. And so, again, there's a number of vitamins and a number of thoughts on that. So I would encourage you to take a look at the article on our webpage for more information. And I did share that link in someone asked the question.
Thank you so much. Are you aware of the incidence of fractures not healing in people with Down syndrome?
Yeah, that's a good question. No, there really is not a lot of information about fractures in people with Down syndrome in the research. Again, I saw that the question. I did share an article that suggests that at least in a couple of mice models that of Down syndrome, that the mice may have a slower healing or poorer healing of fractures. But the article was from 2023, so it's pretty recent. Indicated that there were no really human studies in people with Down syndrome that really had looked at that as well. So the answer, unfortunately, is not really available, although there is some information that suggests that might be a possibility.
Thank you. We also received some questions in advance, and one of those was, does ADHD in adults with Down syndrome lessen as they age?
Yeah, the question is, does attention deficit disorder decrease? Is that
yes.
Clear?
Yes.
Yeah. So that's a great question, and I think attention deficit can be a difficult one to diagnose in people with Down syndrome. So I don't know that we really have the answer to that question. Even the prevalence or the frequency in children with Down syndrome, I think is still being studied, and whether it persists into adulthood, I just don't think we know. I mean, we do not have a lot of people on ADHD medications, but again, I think there's a lot we don't know about this yet in folks with Down syndrome, particularly in adults.
Thank you. Another question was, How much should an aging person with Down syndrome be encouraged to participate in life if they refuse to leave their home? Should they be allowed to just sit and watch TV if that is what they want, or should they be made to get out of their home?
Well, I'm not a big fan of making anyone do anything because I think uh, you know people do have personal preferences and choice, uh, but also I think that a lot of times we see when you make try to make someone do something, they actually just dig their heels in more. So I think we want to continue to make it attractive. Again, we talked about, people's interests change over time. And so we really want to look at, is there something else there that they might be more interested in? Um, Certainly, as individuals age, just like any of us, we may be more interested in activities that are more sedentary. We do want to try to continue to encourage activities, but again, it may be a change with people with aging. So that's a little not really answering the question, perhaps, but there isn't a specific answer to that. I think we want to. It is healthy for us to continue to be active throughout our lives, and that's probably true for people with Down syndrome as well. But again, we just have to kind of continue to look at what the person might be interested in. So I hear frequently, he's no longer interested in doing things because he doesn't want to play baseball anymore. Well, that's true, but there may be something else that he, if we looked at other opportunities, he might be interested in. So I would keep looking for other things that would keep him active.
Thank you. Is diabetes common among adults with Down syndrome?
So yeah, that's a good question. So type 1 diabetes, the type that we develop in childhood, is definitely more common in people with Down syndrome. But it's an autoimmune disease, meaning that the body's immune system attacks another part of the body, in this case, part of the pancreas where the insulin is made, and damages those cells, and then not enough insulin is made. So type 1 diabetes, again, which is more common in kids with Down, is typically onset with children with or without Down syndrome. Type 2 diabetes in our study really was less common, interestingly enough, which I really was not expecting, because we know that obesity is a risk factor for type 2 diabetes, and that people with Down syndrome tend to have more obesity. A study done in the UK, in England, they found that between the ages of roughly, I think it was like 15 or 12 to like late 30s, that type 2 diabetes was more common in people with Down syndrome, which really kind of makes sense to me. In our study, we did not break it down by age. So the answer is still a little bit unclear. But certainly, I think people with Down syndrome would be at risk for type 2 diabetes because of obesity and, in some cases, inactivity. And we'd want to continue to try to address those.
Thank you. Does weightlifting help with osteoporosis in people with Down syndrome?
Yeah, that's another good question. And you could tell from Dr. Graham's presentation that there is a lot we don't know about osteoporosis in people with Down syndrome, unfortunately. And whether DEXA scans are an effective measurement of osteoporosis in people with Down syndrome is a question mark. So I don't think there's a specific answer to that question with regards to weightlifting or resistance training, but we do know that that's beneficial in people without Down syndrome. I would say until we know more, unless we find out something different at some point, I would go with the assumption that it is beneficial. I think it's hard to imagine that it would, be, actually cause problems with regards to osteoporosis. And we know that resistance training is got a lot of other benefits. I think the other important component with regards to fracture, prevention of fractures, is balance. And we know that many people with Down syndrome have somewhat of an impairment of their balance throughout their life. And so making sure that we work on balance as part of the exercise regimen to prevent falls, which does obviously increase people for the risk of fractures in general. So really, I think at this point, unless we find out something very surprising, I would say that people with Down syndrome should participate in really all the forms of exercise that I addressed in the presentation. Not only aerobics, but also, resistance or strength training, balance, and flex. And again, we tend to think of people with Down syndrome as being very flexible, but particularly some as they develop arthritis or other conditions, their flexibility may decrease in certain joints. And so, really attending to flexibility as well can be important for some people.
Thank you. Is sleeping more than 8 hours a night normal as a person with Down syndrome ages?
Yeah, I think that's a pretty individual thing. Sleep is, different for, each individual. We certainly have seen patients that, sleep 10 or 12 hours a day, and then others that sleep, 6 or 7, and both can seem to do well. Certainly there are more sleep disturbances in people with Down syndrome, not only sleep apnea, but, other sleep disturbances as well. Again, so if the person seems tired and needs a lot more sleep, I would go back and look at, first of all, is there a reason for that? Is there some underlying health condition, particularly sleep apnea? And so if there is any sort of sleep disturbance in people with Down syndrome, or there's any question about, whether they're sleeping too much, they're waking too much, or they're sleeping, they're sleeping too little, or they're waking too much, or they're sleeping a whole lot. Sleep apnea certainly would be something I would think about as an early consideration for assessing.
Thank you. There was also a question about whether sleeping more than they did as a younger person is common as someone ages. I don't know if that has a different answer.
Yeah, I'm not sure that it would, I would say, the carte blanche that it's more. But again, I would look at, is there anything else going on that maybe contribute to that from a health standpoint? Certainly, we know as in people with Alzheimer's disease, and I'm not suggesting that's the case here, but certainly people with Alzheimer's disease, they just seem to interact with the world less as the disease progresses, and oftentimes they will sleep more. So I don't know if that's a consideration, but certainly thyroid and sleep apnea and a whole host of other health conditions can cause people to sleep more, as can inactivity. Strangely, when we're more active, oftentimes we have more energetic and we don't need this, we may not need excess sleep. And the more we sit around, the more we want to sleep. So, again, going back to the other question, that can be a challenge to assist a person as they get older to find the right activities or the interested activities.
Great. Thank you so much. Another question was, are adults with Down syndrome more likely to have seizures if they had infantile spasms?
Yeah, I don't know. If that answer is available, I don't know the answer to that question. Certainly infantile spasms are a form of seizure that obviously infants get and can be pretty devastating as far as some of the long-term injury to the nervous system, to the brain. And we certainly do know that they do occur in people with kids with Down syndrome. Seizures in general, we do see sort of two peaks of onset. One is earlier on in life and in childhood, and infantile spasms, would fit into that. That early onset of seizures, but those aren't the only types in childhood. And then later in life, and the ones later in life are typically associated with Alzheimer's disease. And so we do see, as people get out of their 40s and 50s, that the increase, the prevalence of, the occurrence of seizures starting is more common in people with Down syndrome at that age.
Thank you. Oh, goodness. We have so many great questions. Unfortunately, we are out of time. Dr. Chicoine, are there any final thoughts that you want to share with the audience?
Yeah, I would just, I think we really want to continue to work on healthy aging. I think that's an important piece as we learn more. We want to continue to promote health for individuals with Down syndrome, and we really understand and appreciate that people with Down syndrome can participate in that process. So we want them to participate in the way that they would like and they might be interested in. And certainly, if you have more questions, and please feel free to take a look at our resource library, as well as if your healthcare provider has questions, please feel free to direct them to the Down syndrome medical interest group that we included in the presentation.
Great. Thank you so much. And thank you everyone for joining us today. We hope you have a great rest of your day.
Thank you so much.